Hello, everyone, and welcome to the Population Data Science webinar series. My name is Anne Greenwood. I'm the Education and Training Lead for Population Data BC, and it's my pleasure to introduce Dr. Pia Hartlid and Dr. Graziella Faverato, who will be presenting this morning on air pollution, housing, respiratory tract infections in children, the National Birth Cohort Study, PICNIC. By way of introduction, Dr. Pia Hartlid is an Associate Professor of Epidemiology at the University College of London. She leads a number of studies using large administrative health databases to evaluate public health policies for children. She is the principal investigator of PICNIC. Dr. Graziella Faverato is a research fellow at the University College London. She has a background in medical statistics and epidemiology, obtaining a PhD at Imperial College of London on the respiratory health effects of indoor air pollution. Her main research interests are in the use of large observational and administrative data sets and linkage for public health. Before joining the PICNIC study, she worked on administrative data, looking at readmission patterns in mental health care settings in England, and on large international collaboration of observational cohort studies of HIV in pregnancy. So welcome, Pia and Graziella. Happy to have you here presenting this morning. Welcome, everyone, and thanks for joining us. So without further ado, I'll pass it over to Pia.
Great. Thank you so much, Anne, for that introduction. And both Graziella and I are delighted to be able to speak to you today. So we'll be presenting the PICNIC study. We'll explain a little bit of the background and what we'll be doing. Then Graziella is going to show you some very, well, not results, but the sort of more detailed stuff that she's been working on in terms of actually cleaning all the linked data that we will be using. So respiratory tract infections like bronchiolitis, pneumonia and croup are the most common cause of death in children worldwide. And in the United Kingdom and in many other countries, they're also the most common reason for hospital admissions in young children. And as you can see from these news headlines in the UK, admissions for respiratory tract infections keeps going up. And the vast majority of these respiratory infections are due to viruses for which we have that we don't have any effective vaccines for. Now, another striking feature of respiratory tract infections, and particularly respiratory tract infections that are so severe in children that they require hospital admission, is that children who grow up in poorer families are far more likely to be admitted with a respiratory infection than children who grow up in wealthier families. So this slide here, I have stolen from my PhD student, who's now also very delighted to say my colleague, Kate Lewis. And she looked at bronchiolitis admissions in children under 1 year in England between 2012 and 2016. So bronchiolitis causes about 15% of all is responsible for about 15% of hospital admissions in children. In infants, so children under 1. And what this graph shows that Kate prepared is that if you live in the poorest 20% of areas compared to living in the richest 20% of areas in England, you are children who live in these the poorest areas are 50% more likely to be admitted to hospital in infancy with bronchiolitis than if you live in the richest areas. Now, this is a study we published a few years back looking at hospital admissions for laboratory confirmed influenza in children. And there we used young maternal age at first birth as an indicator of low socioeconomic position. And these are population attributable fractions for that study for children under 6 months old. And we found that nearly 20% of all influenza-related hospital admissions could be prevented if children of young mothers had the same risk as children of mothers who are aged 30 to 39 years old. And as I said, we took young maternal age as an indicator of low socioeconomic position, because in the UK and in many other countries, children born to young mothers are far more likely to be living in poverty than children born to older mothers. And we also found similar results for respiratory syncytial virus, so that around 38% of admissions for confirmed respiratory syncytial virus infection in children under 3 years old could be prevented if children are growing up in poorer families at similar risk to children growing up in wealthier families. And it's not just us who found this, it's a very consistent finding across many countries that children growing up in poorer conditions and less wealthy families are much more likely to suffer severe symptoms of respiratory tract infections. But we're still not sure exactly why this is. And this is what we are going to look at in the PICNIC study. So PICNIC stands for Air Pollution, Housing and Respiratory Tract Infections in Children, a National Birth Cohort study, as Anne said. And what we're doing in PICNIC is that we're focusing on exposures to outdoor air pollution and poor housing conditions, like indoor exposure to indoor air pollution or overcrowding during pregnancy and early childhood as risk factors for respiratory tract infections, focusing particularly on hospital admissions for respiratory tract infections in young children. So why are we focusing on housing and air pollution? Well, these are both two major concerns in the UK, and these are just headlines from the last that I managed to find, just published over the last 3 months in major newspapers and TV channels in the UK. So in terms of air pollution, the UK has been found by the Court of Justice of the European Union to have breached legal limits for nitrogen dioxide air pollution since 2010. And there was an environment bill that had been drawn up that was going to introduce quite strict limits for particularly particulate matter air pollution. But this, in January this year, it was delayed again, and it's not likely to be voted on until the autumn now. Now, the COVID-19 pandemic, and we've had a number of lockdowns. We're into our third lockdown in England, and that's highlighted sort of the extremely poor housing that many people in the UK are living in. So people have become very much aware of this during the last year. So that includes sort of the increased risk of SARS-CoV-2 infection for people who live in overcrowded households. And in England, children are overrepresented among households that are, so households with children are overrepresented among households that are overcrowded. And around 1 out of 5 dwellings in England, they don't meet the decent home standards. And the decent home standards are they set a very, very low bar. So, for example, to meet the decent home standards, your bathroom has to be less than 30 years old, and you can't have any category 1 hazard, where category 1 hazards are hazards that cause a sort of immediate risk to life or to health. So, for example, your house has to have a door so that people can't just walk in across the street. So we have a very major problem both with ambient air pollution in the UK, as well as we have an extremely poor housing stock. And so that's why we're focusing on those particular areas in this study. So the aim of PICNIC is to determine the contribution of exposure to outdoor air pollution and adverse housing conditions during pregnancy, infancy, and early childhood to hospital admissions for respiratory tract infections in children less than 5 years old in England and Scotland. And There we go. And in the study, we are going to use, as the title suggests, we are going to use national birth cohorts where children's birth registration records are linked to their hospital admission records throughout early life. But more than that, the babies are linked via the maternity records to their mothers. And so we will also have information on the mother's hospital admission records, so we can look at sort of genetic predisposition to severe symptoms of respiratory infections. So this is our conceptual framework. As I mentioned, we're very concerned about, the whole point of PICNIC is trying to work out really the contribution of air pollution and housing to explaining the socioeconomic differences in respiratory tract infections in childhood. So this is the conceptual framework that we've been working on. So if you look down here, it says RTI severity. You go from being a healthy child, and then there are factors operating on your infection risk. Then you can become infected with a respiratory infection. And then there are factors that affect your immune response and factors that affect how severe your symptoms are, that then lead to severe, that could lead to go on to you develop severe respiratory tract infection symptoms. And then there are factors operating on your admission risk. So eventually you might be admitted to hospital. Now, there are certain sort of intrinsic factors that act on these on this pathway here. So, for example, the age of the baby and the child, the time of the year, that we can't really affect. However, then there are a number of factors, these yellow boxes here, that act directly on each of these that we may be able to, that we think are amenable to interventions. So, for example, here we have infection risks, we have childcare, for example, of both of the child and the older siblings, and the number of the older siblings and the age and number of older siblings could affect the child's admission infection risk. A number of other factors like premature birth, breastfeeding, vaccination history affect the immune response, and things like congenital anomalies and other chronic conditions, prematurity, affect symptom severity. And here we have things related to the care availability, so primary care availability and hospital admission thresholds. And then here in these green boxes is what we're studying, particularly in PICNIC, so outdoor air pollution, and then housing characteristics like overcrowding, indoor air pollution, damp and allergen exposures. Some of these we won't be able to measure in PICNIC, but some of them we will. But then sort of acting over pretty much all of these boxes is socioeconomic position. So we have to be, socioeconomic position is extremely strongly related in the UK. It's not true for all European countries, but it's definitely true in the UK, that they are very, very strongly related to exposure to air pollution. So poorer people are far more likely to live a bit nearer busier roads than wealthier people. And also, obviously, your socioeconomic position affects the quality of housing that you're able to afford. So we have to be extremely careful in the study how we allow for socioeconomic position, because there's likely to be an extreme amount of confounding related to SCP. So there's a bit of a delay in terms of changing the slide. So, yeah, there we go. So what I showed you previously with the mothers being linked to the babies, that was a very, very simplified version of the data that we are going to use, the linked administrative data that we're going to use in the study. So we're going to use a number of linked health and civil registration data sets that are linked to environmental and housing data, some of which are open source. So in terms of the health data, we will be using linked birth registration data to maternity records or birth notifications, as they're called in England, for all babies born in Scotland between 1999 and 1997 and 2020, and all babies born in England between 2005 and 2014. And these birth notifications and maternity records will be linked to hospital and mortality records for both mothers and babies. So we're linking to the mother's records in order to be able to derive things like mother's history of respiratory conditions. And that will will allow us to determine our outcome, which is respiratory tract infections, and also, of course, covariates like long-term conditions in children. In Scotland has an extremely good and well-developed over many years data linkage infrastructure. So in Scotland, we're linking to a number of further data sets, including vaccination records, health surveillance data that's primarily collected by health visitors, but things that contains data, for example, on breastfeeding. We will be linking to community dispensing data in Scotland, so we can not just look at hospital admissions, but also things like antibiotics and prescriptions of asthma inhalers. And then we are linking to public health laboratory surveillance data, and that's primarily for a specific study on COVID that I'm going to talk to you about in a minute. And we also have information on patients who are deemed extremely clinically vulnerable to SARS-CoV-2 infection. So that's a sort of another risk factor for severe. We use that as another risk factor for severe, the high risk of developing severe respiratory tract infection symptoms. So this is our health data. And then in terms of our environmental data, it's in this green box here, and that's collected, we have that available at small area level. So for housing, we have data from energy performance certificates. So if I show you here, so certainly if you're in Europe, but possibly this is available in other countries as well or something similar, all dwellings that are bought or sold has to be evaluated for energy efficiency, and then you get the sort of rating here. And we will be able to link to data either at dwelling level in Scotland or at postcode level in England. So postcode's got about 20 dwellings. And we are also, so that's got data on things like, so energy efficiency, how many rooms there are in the house, what kind of insulation is available, connection to gas main, etc. And one of our partners in the study, Jonathan Taylor from University of Tampere, he's also done some modelling on this data to calculate, for example, indoor-outdoor air pollution ratios and risk of mould. In Scotland, we're also going to link to home energy efficiency database data. So that's information on people who've had upgraded their house, for example, installed double glazing, etc. In terms of air pollution data, so we have annual air pollution data that has been derived from atmospheric transport models produced by the Department for Energy, Food and Rural Affairs. So their annual averages of air pollution for 8 air pollutants at 1 by 1 kilometre grids across the British Isles, including England and Scotland. And then in England, we don't have individual level data on smoking exposure for children like we do in Scotland. So instead, we'll be linking at small area level to tobacco expenditure data. So we have a huge amounts of small area level data that we'll be linking to on environmental conditions. Oops, sorry. And we will link the environmental data via the addressed histories for the mothers and babies, both in England and in Scotland. The National Health Service have address registries for everyone who can access free national health services. So that's pretty much everyone in the country. And we will be linking to those registers to get address histories for both mothers and babies. So we can not just link the environmental data to exposures at birth from the birth registration, but also during pregnancy, and if the child and mother move during pregnancy or during early life, during follow-up, then we'll be able to calculate or derive exposure at their current address. So the air pollution data that we're using that's available for all of England and Scotland, that's both sort of pretty broad, both temporally and spatially. So we do have, we're also linking to daily air pollution data from Greater London for the City of Glasgow. So that's available, as I said, daily at a 100 by 100 metre grid in London and a 50 by 50 metre grid in Glasgow. And we don't have that available for all children, unfortunately. We only have that available for children born 2009 to 14 in Glasgow, about 42,000 children, and 432,000 children born in Greater London between 2010 and 14. So just to say, in the full cohort, we will have 1.4 million children born in Scotland and 6.7 million children born in England. So this will just be a sort of sub cohort of that full cohort. And then we have another sub cohort, which is where we want to link to census data. And that's to get much better information, both on socioeconomic position in particular, but also some further information on housing. So, for example, we need to link to census in order to get data on overcrowding. And so in Scotland, we'll be linking both to the 2001 and the 2011 census record. And in England, we'll just link to the 2011 census. We just had our census for 2021 this Sunday, but we won't have time in Picnic to link to that data, but going forward, hopefully we'll be able to. And that will give us a second sub-cohort, which will be census linked. So that will be for 1.5 million children born in England between 2010 and 12, will be linked to the 2011 census, and then about 300,000 children in Scotland born between 2000 and 2002 and 2010 and 12 will be linked to those censuses. So as many of you work in administrative data research will be aware, to link these kind of data sets requires an enormous amount of ethical and information governance approvals. And for Picnic, we've had to go to 9 committees, so 6 in England and 3 in Scotland. Scotland has a much more centralised system, which is much more helpful for researchers. And this has taken around, we have all the approvals required, including some amendments, and it's taken around 3.5 years to get all these approvals to do the work. So, as I said, we're particularly concerned here about potential confounding by socioeconomic status, given the very, very strong association between socioeconomic status and exposure to air pollution and poor housing. So we're going to use a number of measures in Picnic. So from the birth certificates, there is information, coded information on parental occupation, both from the mother and the father. So that's coded for all births in Scotland, and it's coded for 10% of births in England. And then we have a small area level measure of multiple deprivation. So this is in England, the small area is at around 1,500 people. So it is relatively small. And the indices of deprivation, they're based on a number of domain measures that primarily come from the census. And so a number of these sort of things are measured, including benefits and income. And it is very highly weighted to sort of the proportion of people in the area who are on income support, etc. And this will be mapped to the postcode residence of the mother and the babies. And then, as I said, we will be linking to the census, which has got very much more detailed information on socioeconomic position, like education level, employment, access to resources like access to a car. And we will have this information for mothers. So, as I hinted at before, I mean, every one of us have been affected by COVID-19, and the last year, and the pandemic is still ongoing. And so as part of Picnic, we will be carrying out, because we thought of this, we have the capability and we thought it was so important to do, we will be carrying out a study of the risks of SARS-CoV-2 infection in children. And we'll be doing this in Scotland only due to data availability. In England doesn't allow us to do this. So we will use the national birth cohorts in Scotland. So that's all children and young people born between 1997 and 2020. To determine the risk of having a SARS-CoV-2 test, having a positive SARS-CoV-2 test, so COVID-19 infection, COVID-19 disease-related hospital admission, multi-system inflammatory syndrome in children, which is a rare sort of potentially rare syndrome, potentially related to COVID in time, and a COVID-related intensive care unit stay. And then we will establish how these risks of these outcomes vary according to clinical, family, and socio-demographic risk factors. So that's things like age and sex, obviously, ethnic group, parental migration, being clinically vulnerable or clinically extremely vulnerable due to underlying chronic conditions, but also some environmental factors like tobacco smoke exposure. So, and that's something that Graziella is working on at the moment. So we started the study in July, and we now, I'm pleased to say, have all of those approvals in place, including a number of amendments. We're pretty much there. Graziella has downloaded all the air pollution data and mapped it to postcodes, and she's going to talk about that now. And she's also downloaded the emergency energy performance certificate data and mapped those to postcodes. And we are starting with our colleague Milievich some work to compare air pollution exposure during pregnancy according to the different air pollution data sets we have. So according to sort of different spatiotemporal resolution to see how much that affects our estimates of exposure during pregnancy. Graziella and our colleague Linda has also been working on cleaning and validating English and Scottish birth cohorts, and then deriving study data set and outcomes for the SARS-CoV-2 study. So I'm now going to stop talking and hand over to Graziella, who's going to talk to you about her work getting into the nitty-gritty of linking environmental data to health data. So thank you. Are you there, Graziella?
Yes, thanks, Pia.
Great. Thank you so much, Graziella.
Thank you. So as Pia was said earlier on, the outdoor air pollution exposure in the picnic study is going to be assigned at postcode level. And so far, we have matched the exposure data to UK postcodes using geographical coordinates. And the next step will be to link the exposure data with the postcode of the mother's and baby's home address. So the data sources for the air pollution come from the Department for Environment, Food and Rural Affairs, DEFRA, and Cambridge Environmental Research Consultants, CERC. And details of the postcodes from the Office for National Statistics, ONS postcode directory. So the next slide I was going to show how the DEFRA data about. So we have got data for 8 major air pollutants, PM10, PM2.5, nitrogen dioxide, nitrogen oxides, carbon monoxide, sulfur dioxide, ozone, and benzene. The spatial resolution is 1 by 1 kilometer grid, as Pia was saying earlier on. And what does this mean? It's just that we have got the average exposure over an area, which is the 1 by 1 kilometer grid. And the temporal resolution is annual, which means that we have annual average exposure for these 8 pollutants for 2001 to 2018, which is a little bit earlier for benzene and the carbon monoxide. So the identifier, it will be the geographical coordinate of the grid, and the linking variable to mother birth cohorts is the postcode. For CERC data, which is going to be the next slide, but you can see in pale gray. So we have got data only for 4 air pollutants, PM10, PM2.5, and nitrogen dioxide and ozone. But the spatial resolution is much more fine, is 100 by 100 meter grid. And also the temporal resolution is quite refined, is daily. We have got daily average exposure for these 4 pollutants for 2010 to 2014 for Greater London. And again, as in DEFRA, we have got a geographic identifier, is the X and Y coordinate of each grid cell. And the linking variable to mother birth cohorts is the postcode. So the next slide is about the postcode, and I thought it would be probably for people who were not UK based, just to say something about what is the UK postcode system. So the postcode system UK designs an area with several addresses of a major delivery point. And on average, there are 15 properties per postcode, but it can be anywhere between 1 and 100. In UK, currently there are around 1.8 million postcodes in use. And in Greater London, there are around 380,000. The ONS, the Office for National Statistics, publishes postcode directory twice a year. And this is very useful because it contains lots of data about postcodes, which have been available since the beginning of this system, which is around in the 70s, and also includes the start dates when the postcodes was in use. And and the X and Y geographical coordinates of the postcodes, and which are based on the British national grid. And you can see the map on the right. And this is important because DEFRA as well and CIRC use the same reference system, the British national grid, which makes the mapping quite straightforward. And the next slide is going to show you what we did. We mapped the postcode to the nearest centroid of the square grid, the 1 by 1 kilometer for DEFRA data, and 100 by 100 meter grid for CIRC data. And this is just an example of what I mean for a centroid. So this is the 100 by 100 meter grid. And the red spot is the postcode of our academic institution, Institute of Child Health. And the black dot in the middle is the centroid of the 100 by 100 meter grid. Next slide, please. The next slide is going to basically just telling us what we've done so far. So we have mapped all the DEFRA data to the postcode in England and Scotland. And there are around over 108,000 1 by 1 kilometer grids with at least one postcode. On average, there are 22 postcodes in a grid in England and less in Scotland, 11. And these are huge data sets. So the total size of the data files are around 16 gigabytes. And also, so far, we have mapped the CIRC data to the postcode in Greater London. There are over 111,100 by 100 meter grids with at least one postcode, and on average, 4 postcodes in a grid. And again, these data files are quite huge, around 11 gigabytes. Next slide, please, Pia. This one. So also, so far, we have cleaned the English birth cohort. So we merged the birth registration from the ONS dataset with the hospital episode statistics dataset. And this is diagram showing how we identify the children, how the children identifiers were used to link ONS data set with the hospital episode statistics, where we are going to get the data finally about the admission, hospital admission for respiratory tract infection. I would like to acknowledge Professor Alison McFarlane at City University, who originally developed the data set. Next slide, please. Thank you. And so, as Pia said earlier on, our English birth cohort includes births from 2005 to 2014, any births in England. And so we successfully linked nearly 6 million live births of singleton, linked with a hospital birth record. This is more or less 92.8% of the total live birth singleton in the ONS birth register. And children with missing link are more likely to be born at home or in a private place or in the earlier years of the cohort. We also cleaned the hospital admission dataset, resulting with around 2,250,000 children with a record of hospital admission during the same period, 2005 to 2014. And this is my last slide, and I'll hand back to you, Pia. Thank you.
Thank you so much, Graziella, for giving this is just Graziella made it sound pretty simple and quick, but cleaning, as many of you know, cleaning these sort of linked data sets take a long time, and the next step will be to link the environmental data to each of the birth cohorts. So that Graziella has now mapped. So we need to put this up because we've used data that is held by the Office for National Statistics. So that was all that we were going to say. We are working, Graziella and I are working with a number of project partners, both at UCL, including Linda and Bianca, London School of Hygiene and Tropical Medicine, University of Edinburgh, Tampa University, City University, Public Health Scotland for the SARS-CoV-2 study. And we were delighted also to be working with a number of voluntary organisations, so Shelter, the British Lung Foundation and the Clean Air Parents Network. And we acknowledge funding very gratefully from the Medical Research Council. So this is our last slide. If you want to know more about a picnic study, and just please go to our website. We will be publishing all our code on GitHub, and we'll be publishing, so for example, Graziella's work on mapping air pollution data to postcodes that will all go up on our website to make sure that other researchers can use it as well. So thank you very much, and we're very happy to take any questions.
Thanks very much, Pia and Graziella, for an excellent presentation. Lots of excellent information for people to consider, especially if they're looking at some comparable studies. And so the floor is open now for questions or comments, if you'd like. Just my first question, I guess, to get things rolling. You've mentioned that you're going to be posting code and other things on your site. Do you know when that will be?
As soon as the code will be published on our GitHub page that I didn't put up here, but I can, perhaps I can. That was stupid of me, but I can send that round to people, or people can just drop me a line. It's our group GitHub page. So it's usually the way we've done it previously is when we publish a paper, then we refer to the code in the paper, and then the code will go up there. But as soon as we have sort of cleaned code to share, which should be pretty soon, we will put it up there. And similarly, Graziella has prepared a number of documents discussing how to link, for example, the air pollution data to postcodes, and so that will go up as well. So yeah, within the next few months.
Great, thank you very much. And next steps for your study, what do you anticipate being the next thing that you're going to be working on?
Yeah, so Graziella and our data manager, Linda Velas, are working very hard on the SARS-CoV-2 risk factor study at the moment, because we want to get that out as soon as possible. And of course, that a lot of the work we do for that will be really helpful, like deriving risk factors and things we'll use for the sort of main picnic study as well. And then we will be within the next month or so, sending, or the Office for National Statistics will be sending identifiers to NHS Digital in order to link the cohort to the postcode history, so that we can then attach the air pollution and housing data, and then the English cohort will be ready to roll for all analyses before the summer, hopefully. So those are our next steps.
Great. I know you used a lot of data sets for linkage. Did you have much difficulty accessing the data sets, like just in terms of time and application process?
So going through those 9 committees, so there were more committees because we were looking at data across 2 countries, 2 UK countries. So 3.5 years it took in total, and it's taken a long time. And the other thing is that we're also accessing the data from using trusted research environments, because they're obviously highly sensitive. So we have to sort of log into safe havens at the Office for National Statistics and Public Health Scotland to access them, but that's much less of an issue than actually getting the approvals to access these data in the first place. The reason we're using both England and Scotland as well is that, as I said, for Scotland we have much more detailed data, but Scotland's a smaller country, so by looking at both countries we will sort of get quite a good little picture, I think, of what we can do in England. We may not be able to do in Scotland because of numbers, but on the other hand we have much more detailed data in Scotland that we don't have in England.
Great. Any sort of best practices or tips for researchers who are looking to do comparable studies to yours?
Well, I know there are a number of groups who've done similar studies. So in terms of best practice, I don't know, because we're just still embarking on it. But Graziella might be able to chip in as well. But I mean, I'm particularly keen, and the funding body was very excited that we're sort of very keen on that as well, that we published all our code, and everything is sort of openly available. Obviously, we can't share the data because it's very sensitive, but everything about the data, our code and descriptions about everything that we've done is going to be openly available. So we're very, very keen on that. I should say that our study protocol, if you want to know more about the statistical approaches that we'll take, has been accepted into BMJ Open, so that should be appearing soon, I hope.
Thank you so much again for presenting. A really interesting study, and very timely, just in terms of all the things that are going on worldwide around air quality and health, etc. So thanks again.
Thank you so much. Thank you for listening.